Thanks, Jeff, and thanks, Dimitar, for asking me to come and talk to you all about this. So I'm going to talk to you about what we can offer when the patient's in the ED and the ED can't send them home, really. That's when we get called. So I just want to start by putting things into context and talk about fatal asthma, because I think without knowing the story about that, it doesn't really make sense to talk about what we do. I want to talk about when does standard treatment fail, and then I'll go into specifics about what we can do in the ICU with maximising medical therapy and the ventilatory support we can offer. So there's a report in 2011 on mortality from asthma and COPD. A lot of you might have read that in the room. Roughly there's about 350 deaths a year from asthma, which is about 1.5 per 100,000 population. How that compares internationally, now this is data just for the 5 to 34-year age group, but it's comparable in the other age groups as well. We're about the same as the United Kingdom. And so we all know that asthma is quite prevalent in Australia, but the death rate's quite high as well comparatively. The UK wanted to know why this was happening. And so in 2014, they published this review onto why asthma deaths were occurring. And I think this is really interesting, that 45% of the asthmatics die without any medical attention at all. So they die at home or in the community without ever getting attention. Whether the ambulance is on the way or not, I'm not sure. A further 25% die on the way to hospital, and they're often the ones we see in the resus room who are dead on arrival. And then it's only a third that actually die in hospital, and most of those that die in hospital are basically dead on arrival but have a pulse. So they die of the hypoxic brain injury incurred prior to arriving to hospital. So if you get the severe asthma to the resus room, they should go home intact. So really, the people who can make the most impact on mortality are you guys and not me, by managing them in the community well to try and prevent those severe attacks happening at home before the ambulance gets there. And the risk factors are quite obvious, but they're worth stating. That there's the disease risk factors that we all know about. If they've had previous near-fatal asthma attacks, if they've had lots of admissions, they're going through their puffers a lot, and if they're on more than 3 classes of medication, they're at risk. But probably the more important ones, which are the more challenging ones to fix, are the social and behavioural ones. So the disadvantaged people with asthma are the ones that are at risk of suddenly dying at home, and that will be related to compliance, access to healthcare, etc. So they're the things we should be focusing on, not the fancy ICU management, really. Having said that, we still have something to do for you, for your patients. Jeff and I actually looked after this patient last week in Flinders Medical Centre. I think Jeff looked after her. That's not her photo, that's from the internet. But a 31-year-old woman was in the ED failing standard treatment. This is a common story, as I'm sure you're aware, was getting continuous salbutamol nebs, had the 3 atrovent nebs in the first hour, had been given some IV steroids, had the obligatory emergency department magnesium dose before calling ICU. I'll talk about that a bit later. And they put her on the BiPAP machine in the resus room. And we were called to come and see her because she wasn't responding to the continuous salbutamol nebs. This is the blood gas, and someone's ticked and crossed and circled things here for training, I suspect. But she had a pretty typical ABG for a severe asthma that we don't get worried about, even though she's on the BiPAP. So the thing that doesn't make me worry is that her CO2 was low. It's quite common for these patients when the CO2 is low. It normally means they don't need to come to ICU necessarily. The oxygenation was good on 100% oxygen. Potassium's a bit low, lactate's a bit high, glucose is a bit high. So those that are into pattern recognition would spot this straight away, what's going on. So you've got the options here. Do you bring her to ICU and get the tubes out and the drugs out and get everyone ramped up to intubate her? Do you give her a stat dose of IV salbutamol to treat that tachypnea and breathlessness? Do you give another dose of magnesium? Or do you stop the salbutamol and remove the BiPAP and see what happens? I think we all know what we need to do. So that leads on to why does standard treatment fail? And this is anecdotal, really, but all my colleagues would agree with this list, I think. That usually when we get called, the first thing we think of is, have they given them too much salbutamol? And this can be difficult because obviously it'll be a subtle transition from the respiratory failure from the asthma to the tachypnea of acidosis. And the clues we look for are what the CO2 is doing, and we might do serial gas, but also when we examine them, they move a lot of air when they've transitioned. The wheeze has gone away, but they're moving a lot of air. So the other thing to think about, asthma mimics, which have been touched on in the previous talks, and near-fatal asthma, of course, is what we're worried about and what we want to treat, and complications of near-fatal asthma. So salbutamol toxicity, just to summarise the issues, continuous nebs will do it, IV will certainly do it, and we see it frequently. We see it a lot in kids, actually, in our hospital. Lactic acidosis from the increased muscle anaerobic metabolism and the tachypnea. It worsens VQ mismatch from pulmonary vasodilation, and they can get arrhythmias, particularly with the hypokalemia associated with it as well, and they get agitated. And most often we do still bring them to the ICU because we might still need to treat their severe asthma, but just at a reduced salbutamol dose. So usually if they've had enough salbutamol to get toxic, it usually suggests that they are bad enough to have a short stay in ICU, where we usually just watch and wait. The asthma mimics, now I'll put anaphylaxis up the top there because occasionally we get called around to see an asthmatic and what they need is some IM and adrenaline. It's rare, but sometimes the skin changes are subtle or a mist or not there. So it's always in the back of my mind when I get called to severe asthma in the resus room that maybe they've got anaphylaxis. We've touched on this, Anthony touched on this in the last court. The vocal cord dysfunction is a group we see, and we often see them frequently and repeatedly. And they've often got stories of other hospitals intubating them in the resus room by the ED staff. They've often had frequent courses of steroids, and they can be a challenge because they often do have asthma as well. The cardiac asthma does exist. We see that a lot. Patients with pulmonary edema that we need to just diurese and do an echo and sort out their heart failure. And we've had a few cases in the last couple of years where on intubation we've discovered they've actually got laryngeal tumours, and that's why they weren't responding. Now, I don't want to go through all these, just to remind you of the criteria for severe asthma. And basically, life-threatening asthma is when severe asthma makes you tired or worsening respiratory failure or you have a silent chest. The asterisks there just show that the things we usually use, as the patients become more severe, they don't have the ability to do your spirometry. And I have to say that emergency departments are rarely using this now. They usually, if they're sick enough to be in the resus room, they don't pull out the peak expiratory flow. Maybe they should for some of these patients, but they don't usually. Pulsus paradoxus requires as a good inspiratory effort to cause that pressure differential with a negative intrapleural pressure. If they're really sick, they might not be able to produce that. But they're your pretty standard triggers to call it life-threatening asthma down the bottom there. Now, I'm not an immunologist or a basic scientist, but in autopsy studies, there are these two classic types of asthma presentations with life-threatening asthma. The most common one would be the patient who's known to the clinics who are on lots of medications who get a respiratory tract infection and come in with a lot of mucus inspissation, a lot of bronchial inflammation and bronchospasms, are less of a feature than the second type, which is the hyperacute type where the person may or may not know they're asthmatic and get a trigger for whatever reason and then become extremely tight with a silent chest and they can arrest in front of you after a few hours or even minutes sometimes. The thunderstorm asthma may explain a lot of these patients. And they're the ones that get better quickly as well if you can catch them in time. So when do we get involved as intensivists? Well, usually it's when, as we described that first case presentation, the ED have put on the BiPAP because they've already given the salbutamol nebs, the rescue Atrovent nebs, first dose, one dose of magnesium and the steroids. Now, what does ICU have to offer? And I'll go into detail with these a bit more, but usually what we do is continue what was happening in the ED and watch them and have a skilled airway doctor around the place. I do very occasionally give a stat dose of IV salbutamol, even though the studies say that it doesn't give a better delivery. But sometimes you just can't help yourself. When you've got a patient there, the silent chest, you just want to make sure it's getting in there. And it's not science-based, it's just, you just want to... So often we do give a dose. I'm very cautious about giving infusions, though, of IV salbutamol. Ketamine infusion is becoming very trendy, but the doses given, which I'll show in a minute, are basically anaesthetic doses, so you really need to be intubated. For it to be effective as a bronchodilator, they're very high doses. And we can give high-flow oxygen if they've got a bit of atelectasis, etc. NIV intubation, ECMO. So just the magnesium story, I think it's worth just going through that. There were lots of small studies which culminated in this meta-analysis in 2007, which showed that in children it did seem to improve spirometry in the ED and reduce hospital admission rates. Adults, it didn't seem to improve it. So just going on to the forest plots there, you can see that this is for peak expiratory flow rates, that the adult's diamond does touch the line there, where the kids, it does seem to help. Now this is a single dose of magnesium I'm talking about here. And admission rates, it seems to get kids home more often from the ED than adults, not so sure. But then the lead author on this also was the same author from that last paper. This was published in the Lancet Respiratory Medicine in 2013, and this was actually quite a well-designed trial where they compared intravenous with nebulized and placebo in patients that met those severe asthma criteria that I put up earlier. But what they found was, and this was well done with sham treatments, those that everyone got a nebulizer, everyone got a bolus, so it was well blinded. But the nebulizer is definitely out, and intravenous may have a limited role. Now, where do they get that? This is their results tables. What's worth pointing out with this one, this is the lung function at 1 and 2 hours post randomization and post dosing. The thing to point out, I think, is that on their baseline peak expiratory flow rate, severe asthma is defined as less than 50% of your predicted. In the intravenous group, the mean was 54. So some of these patients were being classified as severe asthma without reaching the peak expiratory flow rate. So maybe they weren't sick enough, is the point to make here. But having said that, across the board, there was no difference for nebulizers versus intravenous versus placebo in the changes in peak expiratory flow rate at 1 hour and 2 hours. And this is the graph for the hospital length of stay. It's in hours, so really what they're looking at is discharge from the ED here, and a little bit of separation here with intravenous, so that's where they say it may be beneficial for discharge from the ED, but really as time goes on, it probably doesn't make much difference. Then the Cochrane came out, which included that study I just mentioned a year later, with a slightly different conclusion. They were saying that a single dose does reduce hospital admissions and does improve lung function. So when they pulled all those data together from all the trials, that's what they came up with. But it has to be in the subgroup of patients that aren't responding to the first-line treatments. So this is from that Cochrane paper, which just shows that if you treat 100 patients in the ED with magnesium, if they're not responding to treatments, you save 7 hospital admissions. So the conclusions that I've come to is that it's probably reasonable to give a single dose in the ED if they're not responding to, and when do you call non-response? I mean, that's a difficult one, but when they're not responding to the bronchodilators, a single dose is unlikely to cause harm, and it may benefit the patient, probably benefit them by getting them out of the ED. This is the Australian guidelines. It's probably too small for you to read, but just to show that magnesium does come in down here. This is the current Australian guidelines for acute severe asthma, for life-threatening asthma. It does come in under your 3 doses of atrovent in the first hour and after your continuous salbutamol. And this is the British guidelines. That's 2016. You can't see that there. And this is the British guidelines. Actually, I would recommend you read that one. It's a really good evidence-based document. Their recommendation of level A recommendation is forget about nebulized, and their level B is that if they do have a peak flow less than 50%, then a single dose is fine. Repeat dosings I would caution, because as you're aware, magnesium, hypermagnesemia causes muscle weakness, including respiratory muscles. And so you can precipitate respiratory failure and arrest if you're giving another dose. So usually it's already given when they get to us, and so we don't even think about it as an option. Ketamine, there was a review in 2013 on ketamine. It's an anaesthetic we use a lot for analgesia, and it's actually the go-to anaesthetic induction agent now across the board, pre-hospital, ED, and ICU. It's had a resurgence, it's an old drug, but it does have bronchodilator effects. But to get those bronchodilator effects as an infusion, you're pretty much giving them a general anaesthetic. So the dose ranges in the studies were quite broad, but 2.5 milligrams per kilogram per hour, that's a lot. That will make someone lie there and look into space, or spaced out in the general anaesthetic. It has shown improved lung function on intubated and non-intubated patients. So we do use it, but I don't think it's something to use before they get to us, really. Things that have shown not to be effective, aminophylline. In children, there has been some evidence that it is useful. I think this is, with things like ECMO, this last-ditch effort with aminophylline infusions doesn't really occur anymore. It does have a very narrow therapeutic index, as I know you're all aware, and with our patients that are already crook, we don't want to give them arrhythmias. Heliox shows promise to decrease the work of breathing by reducing the density of the air, but isn't borne out in studies. And leukotriene antagonists in the acute setting don't work. Empiric antibiotics don't have anything to offer either. And there's some Cochrane's around these issues. So getting on to some physiology, what we're dealing with. So when the patient has failed those first-line treatments and they've had the magnesium and they're on BiPAP in the resus room, this is when we start worrying about the dynamic hyperinflation story. So it's when they have incomplete emptying at the end of their inspiration because lung units are emptying at different rates. The onset of inspiration occurs before all those lung units have been emptied, and so you start to trap your air. And the result of that too is an intrinsic PEEP, which makes it difficult to start your inspiration. So this is just a schematic diagram to show what happens as you're getting more and more severe asthma. Now, the severe asthmatics that you see in the clinic are already operating at a higher FRC than normal, and so they're already at a slightly mechanical disadvantage with their tidal breathing. Your normal FRC with tidal breathing is the sweet spot for all your lung mechanics. So as soon as you're getting up above your normal FRC, worker breathing is increasing already. So then when they get their acute attack over here and have lung air trapping, what's happening is your FRC is creeping up towards your total lung capacity. And so the diaphragm's flattening, lungs are expanding, they're trying to maintain their minute ventilation. They get a sense of anxiety because they're getting awareness of their breathing, and that's when the CO2 is low. As that continues, and the air trapping continues and the bronchospasm continues, their FRC is getting closer and closer to total lung capacity. And so their ability to maintain that minute ventilation is reduced, and their dead space fraction of ventilation is increasing. So that's when your PaCO2 normalizes. And for some patients that means they're getting better, but for most of them it means they're getting worse. And this is when we really worried about the patient, when that repeat blood gas goes from 22 CO2 to 35 to 40, and the patient looks like they're getting better, but you listen to their chest and they're not moving any air. They're getting better because they're looking fatigued. They're looking better because they're getting fatigued. And so they're in real trouble. So this is when we start thinking about what can we do to help them. And NIV is usually just whacked on in the ED these days anyway. So we have a decision, do we keep them on NIV or do we intubate them? So let's talk about the NIV story. Sorry if I run over time, I've got a bit to go yet. Let me know if I need to cut it short, Jeff. Okay. So the NIV story, the first thing it does is it offsets that threshold work required to start your inspiration. Because you're trying to, it takes a while for the flow to occur after inspiratory effort occurs with the intrinsic PEEP. So this offsets that by giving a bit of PEEP, external PEEP. Improves oxygenation by improving VQ matching, and we can also obviously deliver higher concentrations of oxygen. It shortens your inspiration time, which allows you to improve your minute ventilation and improve your IE ratio without worsening dynamic hyperinflation. So these are all good things. And it improves bronchodilator response. Of itself, it can cause bronchodilation, but also delivery of bronchodilators. And the Cochrane review was done on this, but really there's not enough evidence. So this is one of those situations where it's probably an absence of evidence rather than evidence of absence. There's only 6 small studies, and what we're looking for is, does this reduce intubation rates really? That's what we're after here. And we don't know. It may do. But interestingly, just yesterday when I was looking at this again, there's a paper that has been published ahead of print online, and it's not yet published. This is just a case series, but it's a good case series in Middlemore in New Zealand. It's 16 years of experience. They had 265 asthma cases, of which 186 were on NIV, and only 8 of those needed to be intubated. Now, were they sick patients? Well, they were sick patients. Some of them, this is just looking at their CO2s and their pHs. I mean, if you look at the interquartile ranges, this is in KPA, but I mean, we're getting up here with high CO2s, and the traditional teaching is you don't put NIV on the high CO2 patients. We'd normally intubate them. But these guys were pushing the envelope, putting them on patients with high CO2s, and in the paper body itself, it says that some of them had decreased conscious state. So treating more like a COPD patient, where we traditionally would happily do that. They were doing it in the asthma patients without a high intubation rate, so that was interesting. And they were quite severe clinically, with most of them only speaking in words or not being able to speak at all. So these were a sick group of patients which they were able to avoid intubating in a vast majority. So we all tend to do a trial of NIV, and what we're thinking is we're putting the NIV in while we're bridging that therapeutic gap, waiting for the steroids to kick in more than anything. That's the main thing we're hoping will happen. We're hoping to prevent intubation, but really this should be done with an intubating doctor at the bedside, ready to pounce when things go pear-shaped. But please remember to exclude pneumothorax, because we have a recent case where the pneumothorax, which can be subtle in asthmatics, as I'm sure you're aware, wasn't excluded, and that they did badly. Hypercapnia, I think it can be done, which I didn't used to think, but the middle more experience makes me wonder. But don't delay intubation. So it's usually the study modes are BiPAP modes, and the EPAP, we can't measure intrinsic PEEP on non-intubated patients, but we can fiddle around with the EPAP to try and get the sweet spot to offload that intrinsic PEEP without contributing to it. And you can do that by just dialing up your EPAP slowly until the patient feels, their inspiration feels better. So intubation indications: respiratory arrest, cardiac arrest, exhaustion, rising CO2, hypoxemia. Seems easy when you list it, but when you're at the end of the bed, it takes a bit of judgment. It is a high-risk procedure, intubating these patients. It's not uncommon to have a cardiac arrest on induction, and I'll explain why that is in a minute, but usually it's because you've made their dynamic hyperinflation worse. You've paralysed them now, so their FRC can go above total lung capacity, and what that does is then compress your right heart, so you're not getting venous return. The drugs we just gave vasodilated them, so another reason that their preload goes down. They might not be properly pre-oxygenated, because it's often under duress you're doing this, and you make hypotension pneumothorax. So you really need to be vigilant when you're putting that tube down on these patients. So this just shows you what happens when you intubate a patient and you start doing positive pressure ventilation. You can now get total lung capacity, FRC above total lung capacity, because you paralyze your respiratory muscles in the chest wall can just expand as the lungs expand. And so your FRC is right up there. And that's when you get the cardiac arrests and the risk of tension pneumothorax. So what I do and what most people do is they'll put the tube down, and they'll give one breath to confirm position, and they'll just wait. And I'll often put a stethoscope on the chest, wait for the wheeze to go, then give my next hand breath. So we often will hand ventilate them for a good couple of minutes until we're happy that we know how many breaths they're going to tolerate on the ventilator. Then we'll put them on the ventilator and we'll give them nice, slow breaths. We'll heavily sedate them and paralyse them. We'll let the CO2 climb, trying to keep pH above 7.2. We'll fix the ventilation so they've got a long expiratory time. And the traditional teaching was to have no PEEP, but now they're thinking that if you add a little bit of PEEP, you might actually open up some lung units that aren't communicating. With zero PEEP, if there's a trapped gas with a blocked bronchiole, then that's not going to be accessible unless you add a little bit of PEEP. So there is an argument to add a little bit of PEEP as long as you're not causing worse intrinsic PEEP. Now that they're ventilated, we can actually do some monitoring and see what's really going on. So once the tube goes down, we can actually look at their respiratory mechanics and look at their airflow limitation and really get a good idea of what's going on with them. So this is what we see on our monitors, on our ventilators. So this is a mechanical square wave inspiration with constant flow, and this is the expiration phase. And the dotted line is what normally happens. The flow goes to zero before the onset of inspiration. With asthma, if you're not careful when you start your inspiration too early, then that's when you start getting your gas trapping, and your auto PEEP comes into play there. We can also do an inspiratory pause maneuver where we just hold the ventilator on inspiration and hold up the lungs for 1 second or so, and that'll give us information about the plateau pressure and also the peak pressure. Now the peak pressure is interesting because asthma is heterogeneous and there's variable amounts of mucus inspissation and bronchospasm and thickening of the bronchial wall. The peak pressure you measure at the trachea doesn't necessarily represent what's going on in the lung. You might have a peak pressure of 80 in some lung units or some alveoli, and that's when you're going to pop. The plateau pressure, on the other hand, is an average of all the open alveoli. So we would like to have a plateau pressure less than 25 and a peak pressure less than 60, knowing full well that some areas of the lung might have a peak pressure in the 80s. We also, looking at intrinsic peak, we can now measure that because they're ventilated. We do an expiratory pause manoeuvre, and we wait a while for those units to equilibrate, and it gives us an idea of what their intrinsic peak is. And again, heterogeneous lung, different amounts of intrinsic peak in different parts of the lung. So you can see now why that barotrauma is a real problem with dynamic hyperinflation, even if you are measuring IPEEP. Attention pneumothorax, obviously very, very dangerous. Hypotension from that right heart compression, cardiac arrest, as I've mentioned. The synchronies, often we need to keep them ventilated, heavily sedated and paralysed for a day or more, which often leads to the problem of myopathy and weakness. So you're giving high-dose steroids, neuromuscular blockade, there's a high risk of getting critical illness weakness, which prolongs their ICU stay, and you can get pneumonias and lung injuries from the ventilator itself. Now, I just want to make some comments about pneumothorax in general, but also in the ventilated patient. I find the diagnosis of pneumothorax in asthmatics very difficult clinically. And one thing that we see, and we often see this in the pre-hospital environment, and often in the patients, unfortunately, who arrive deceased, they often have 2 needles sticking out their chest. And it's hard for the ambulance officers to know the difference between a silent chest from dynamic hyperinflation and from bilateral tension pneumothoraces. But I think we can be a bit more sophisticated in hospital, and I really don't like seeing blind needle chests in the asthmatic in hospital. There are ways to decide whether that's dynamic hyperinflation, severe bronchospasm in the intubated patient as the tube gone down the right main bronchus. So we do like to get a chest x-ray or do a bedside ultrasound. If you do have to urgently decompress a pneumothorax in these patients, we go for a blunt dissection technique in the ventilated patient, which is safe. So we cut the skin and dissect bluntly and open up the pleura that way. That way, if we get it wrong and it's just dynamic hyperinflation, then we haven't injured the visceral pleura. So this is just to show, sometimes it's obvious in pneumothorax, but sometimes a pneumothorax in a ventilated patient who's lying flat is actually anterior, and a chest x-ray will look normal. So that's when ultrasound can help. This is just an ultrasound still which shows the lung coming up, and that's called lung point. If you put the ultrasound beam where this arrow is, you see lung coming in and out of your ultrasound field, and sometimes that can assist deciding whether to drain that. I mean, you can go to CT, but that's a bit more of a hassle with a ventilated patient, and particularly if they're unstable. So when do we stop ventilation? Well, we monitor the intrinsic PEEP, and we look at that flow pattern on the ventilator, and once we think that's improving, we reduce the sedation, and then we change them over to a spontaneous mode of ventilation, where just pressure support ventilation. And at that time, we then try to creep up on the on the PEEP that we're applying with the ventilator to offload that threshold work of inspiration again for the patient. And we're trying to get a sweet spot of about 80% of their intrinsic PEEP, and that way, when they want to take a breath, they've already got a head start with the PEEP that's applied. So just as a last comment on what we can do, I haven't done it in Adelaide, but there's case reports and case series of patients who just aren't getting better with all those techniques and that need to go on the VV ECMO. And it certainly is a rescue therapy that we can do in most tertiary centres now in Australia. If they've got bad barotrauma and multiple pneumothoraces, then that's a good way to do it. Hypercapnia would be the other reason when we're able to ventilate them, but we can't control their CO2. Hypoxemia is quite rare in these severe asthmatics unless there's pneumonia and bad atelectasis. So in summary, I think the people in the room here can impact the mortality of asthma a lot more than I can. You've got to exclude those asthma mimics. We just continue what you guys are already doing in the ED and in the clinics. Bronchodilators and steroids are still the mainstay of treatment. Watch for subbutyl toxicity, magnesium, but not repeated. NIV, I think, is definitely worthwhile, but you've got to be ready to intubate them and be prepared for that post-induction cardiac arrest, which you should be able to reverse with careful ventilation strategies. And permissive hypercapnia is really a life-saving strategy. ECMO's there if you need it.